Good evening all. On behalf of IRIA Kerala, I welcome all to the IRIA Kerala PG case discussion on genitourinary system in association with JournoMed. Towards this, I welcome President Kerala IRIA, Dr. Rijo Matthew, Secretary Kerala IRIA, Dr. Ramesh Shenai, Program Coordinator, and Dr. Tara Pradap, Head of the Department, Lakeshore Hospital, Kochi, Zonal Coordinator. And today, probably the last part in the genitourinary system. And next month we will start on next system. We will be moving on to the next system. And today, actually, our faculty who is going to guide the PGs for the presentation is none other than Dr. Dhanya Jacob. She is Senior Consultant in Lakeshore Hospital, Kochi. I welcome Dr. Dhanya for this. And once again, welcome everybody. And now over to Dr. Tara for the introduction of the faculty as well as the students.
So,
over to Dr. Tara.
Yeah. Good evening all, and I welcome you all to this session on PG case presentation on genitourinary system conducted by the academic wing of Kerala IRIA 2022. And I welcome all the masterminds behind the program. And the faculty for today's session is Dr. Dhanya, who is an enthusiastic academician from Lakeshore, Kochi, and I welcome you to the session. She did her post-graduation from Medical College Trivandrum and has been an active participant in all our academic activities. And we have with us two of our PGs, Dr. Amrita and Dr. Shruti. And I think we'll straight away begin the case presentation. So we have two case presentations for today. And Dr. Amrita would be presenting one case and Dr. Shruti would be presenting the other case. And this would be followed by a short quiz session. And there are 10 cases and 5 cases will be for the first participant and the next 5 cases will be for the next participant. And I hope all of you would enjoy this session and would get benefited from this session. And now I over to Dr. the PGs for the presentation.
Good evening to all. I am Dr. Amrita Aravind, DMB resident, Lakeshore Hospital Research Center, Kochi. I am presenting a case of 1-year-old female child born out of non-consanguineous marriage, and she was presented with a lump in the right side of abdomen. And initially, she was evaluated with ultrasound abdomen, which showed a large heterogeneous mass in right lumbar region, which is seen originating from right kidney. This is the ultrasound image of left kidney, which also shows a lobulated hyperechoic lesion in the lower pole of left kidney. Followed by this, the patient underwent MRI. Axial T2 weighted images. Showing a large, well-circumscribed lobulated mass, showing T2 hyperintense areas in the anterior aspect and T2 isointense area in the posterior aspect, which is seen arising from upper pole of right kidney. Here, the close sign is demonstrated where we can see there is a sharp margin between the mass and the right kidney. The interface is seen clearly, which tells us that the mass is arising from right kidney. And the mass is distorting the right renal parenchyma and also the pelvic calyceal system. And there is dilated calyces seen in the right upper pole. The mass is compressing the right renal vein posteriorly, and it is medially compressing the inferior vena cava also, compressing and displacing the inferior vena cava, and anteriorly abutting the anterolateral wall, abdominal wall, and inferiorly displacing the bowel loops. Left kidney also shows heterogeneous lesion involving the interpolar region of left kidney here, and another contiguous heterogeneous lesion with hyperintense areas is also seen in the lower pole of left kidney. Few low volume para-aortic lymph nodes can be seen. No evidence of any liver lesions. Spleen gallbladder appears normal. No evidence of ascites. And this is the axial and coronal T2-weighted images showing demonstrating the close sign, but the interface between the mass and the kidney is well demarcated. And this is the axial T1 weighted image, where the mass is the T1 hypointense signal is seen in both the lesions in both the kidneys. And this is the diffusion weighted images showing diffusion restriction areas of right renal mass, predominantly involving the posterior aspect. And this is the left renal mass, which also show areas of diffusion restriction. This is the axial post-contrast images showing heterogeneous enhancement of the right renal mass, predominantly involving the posterior aspect with non-enhancing areas in the anterior aspect. And the lesions in left kidney also shows enhancing areas. No evidence of any thrombus in the renal veins or inferior vena cava. So based on the imaging features, the diagnosis was bilateral Wilms tumor, stage 5, with a renal nephrometry score of 8H, that is moderate complexity. So the differential diagnosis include rare possibilities of other malignant primary renal masses like renal cell sarcoma, rhabdoid tumor, and rarely renal cell carcinoma. Where in renal cell sarcoma, there will be early metastasis to the bones, and rhabdoid tumor, there will be a synchronous primary or secondary posterior fossa lesions in brain, and renal cell carcinoma is very rare and it is usually in older age group. So a few words about renal nephrometry scoring system. It is developed to categorize the renal masses into low, intermediate, and high complexity based on cross-sectional imaging findings. And it is used to aid in decision-making, patient counseling, surgical and patient follow-up. This is the table showing the components of the nephrometry score, which include, first is the radius, that is the maximal diameter. 1 point for if the diameter less than 4 centimeter, 4 to 7 centimeters, 2 points, and more than or equal to 7 centimeters, 3 points. And next component is the exophytic or endophytic properties. That is, if the mass having more than or equal to 50% exophytic component, then 1 point, less than 50% exophytic component, 2 points, and entirely endophytic, 3 points. And nearness of the tumor to the collecting system is the next component. And in millimeters, if it is more than or equal to 7, 1 point, 4 to 7, 2 points, and less than or equal to 4 mm, 3 points. And anterior and posterior extension, no points given, it is assigned as A, P, or X based on anterior posterior extension. And location relative to the polar lines is the next component. If it is entirely above the upper or below the lower polar line, it is given as 1 point. And if lesion crosses the polar line, then it is the 2 points is given. And if more than 50% of mass is across polar line, or mass crosses the axial renal midline, or mass is entirely between the polar lines, then 3 points is given. And based on the scores, if score of 4 to 6 low complexity, score of 7 to 9, moderate complexity, score of 10 to 12, high complexity. So our case had 8 HX, that is moderate complexity. So this patient underwent PET-CT for metastatic workup. This is the axial PET-CT images showing PET uptake in the posterior aspect of the right renal mass. Also in the anterior aspect also. And also the left renal lesion also show areas of PET uptake. And there is no evidence of PET uptake in any other elsewhere in the body to suggest metastasis. The patient underwent Bruken biopsy from right renal mass and it showed necrosis. Because as we have seen the images that in the anterior aspect of the mass, there were predominantly non-enhancing areas likely due to necrosis, and the enhancing salt components was in the posterior aspect. So the biopsy could yield only necrosis. Whereas Bruken biopsy from left renal lesion showed perilobar nephrogenic rest. So the patient further underwent a right radical nephrectomy, and histopathology from the mass showed Wilms tumor. And further, the patient underwent ultrasound, multiple follow-ups with ultrasound abdomen, which showed increase in the lesion in the left kidney. And further, MRI was done for follow-up, which showed increase in enhancing areas of the mass in the left kidney. And in the next MRI follow-up, again, there is increase in enhancing salt components involving the left kidney lesion. So again, repeat Bruken biopsy was done from left renal lesion, which showed Wilms tumor. And the patient was initiated on chemotherapy. And following chemotherapy, again, a repeat MRI was done, which showed reduction in enhancing components with increase in cystic areas. And the patient is planning for surgery. So coming to a short discussion of Wilms tumor. Wilms tumor or nephroblastoma accounts for 87% of pediatric renal mass. And the peak incidence is at 3 to 4 years of age. Coming to genetic predisposition of Wilms, it includes abnormal WT1 gene, which is associated with Weger syndrome, that is Wilms tumor, IRIA, genitourinary abnormalities and mental retardation, Dennis-Drash syndrome, that is triad of Wilms tumor, male pseudo-hermaphroditism, progressive glomerulonephritis. And next is an abnormal WT2 gene, which is associated with Beckwith-Wiedemann syndrome. Hence, children with these syndromes need a screening from 6 months of age to look for early development of Wilms tumor with CT, followed by serial ultrasound every 3 monthly up to 7 years of age. So, briefly about the imaging features of Wilms tumor, it is a well circumscribed mass due to pseudocapsule, and the enhancement is usually less than adjacent renal parenchyma. And the mass is heterogeneous with solid and cystic areas and areas of necrosis, and hemorrhage and fat attenuation may also be present. And it will distort the parenchyma and collecting system or may invade them. And vascular invasion of the renal vein and inferior vena cava can also be seen. And it can spread by direct extension and displaces the adjacent structures and does not encase or elevate the aorta usually. And metastasis, the most common site is to lungs, that is 85%, followed by liver and regional lymph nodes. So there's a staging for Wilms tumor, that is SIOP staging system. According to that, stage 1, the mass is confined to the kidney, and here the complete resection is possible. Next is the stage 2, local spread beyond kidney, including the renal vein involvement. There also complete resection is possible. Stage 3 is lymph node involvement or disease confined to the abdomen, that is peritoneal spread residual tumor. Here complete resection not possible. Stage 4 is a hematogenous metastasis, typically lungs, liver, distant nodes, and stage 5 is bilateral linear involvement. So here, in our case, it was a stage 5 Wilms tumor. So initially the left kidney, in our case, the left kidney showed biopsy from the left renal lesion showed nephrogenic rest, that is perilobar nephrogenic rest. So coming to the nephroblastoma. Nephrogenic rest is a foci of metanephric blastema that forms the kidney if persists beyond 34 weeks. Usually the kidney is developed from metanephric blastema, which usually disappears at term, but if it persists, it is known as nephrogenic rest. And evidence of nephrogenic rest is present in approximately 1% of infants. And if it is diffuse or multifocal involvement, that is known as nephroblastoma. And it may usually resolve on follow-up or has the potential for malignant transformation to Wilms tumor in 1%. Coming to types, that is perilobar type, which is more common, which is present in, usually the lesion is present in the periphery or cortex, in the case of 75 to 80%. Intralobar, the medullary is less common, that is 20 to 25%, and the nephroblastoma, that is a diffuse form. The differentiating features of perilobar and intralobar. Perilobar, you can see the kidneys are enlarged with a peripheral, well-demarcated rind of tissue, and histopathology shows a blastemal tissue which predominates in the perilobar rests. And intralobar type, usually the lesion is central towards the medulla, and histopathology shows a stromal or epithelial tissue which predominates in the intralobar rests. So nephroblastoma versus Wilms tumor. On imaging, nephroblastoma is more homogeneous than Wilms tumor in all imaging modalities. And presence of pseudocapsule, contour bulge, and heterogeneous enhancement favors transformation into Wilms tumor. So this is a table showing differences between Wilms tumor and neuroblastoma. So Wilms tumor, the age of presentation is 3 to 4 years, whereas neuroblastoma 1 to 2 years. And constitutional symptoms is uncommon in case of Wilms, whereas pain, paraneoplastic symptoms can be seen in neuroblastoma. Claw sign is present in Wilms tumor, whereas absent in neuroblastoma. Margins are well defined due to pseudocapsule in case of Wilms, whereas it is ill-defined in neuroblastoma. Calcifications are uncommon in Wilms tumor, usually curvilinear or coarse, whereas neuroblastoma calcifications are very common, which is stippled calcifications. Vessels, they are displaced rather than encased in case of Wilms tumor, and it can also infiltrate the vessels. Whereas in neuroblastoma, it usually encases the vessels and the aorta gets uplifted. In spinal extension, absent in Wilms, present in neuroblastoma, and Wilms tumor usually do not cross midline, and it may cross midline. Neuroblastoma may cross midline. The image showing the differences. This is a Wilms tumor, showing smooth contour due to capsule with extension to venous system and showing a close sign. And calcifications are uncommon. Whereas neuroblastoma, they are ill-defined due to absence of capsule. It crosses the midline, encases the vessels, and calcifications are common. Now about a short discussion about pediatric renal masses. So the pediatric renal masses are classified into primary malignant, secondary malignant, and benign neoplasm. The primary malignant tumors include Wilms tumor, renal cell sarcoma, rhabdoid tumor, renal cell carcinoma, and PNET. Secondary involvement by malignant tumors include neuroblastoma, leukemia, and lymphoma. Whereas benign neoplasms include congenital mesoblastic nephroma, multilocular cystic renal tumor, metanephric adenoma, angiomyolipoma, nephroblastoma. Clear cell sarcoma is a rare aggressive tumor with a mean age of 36 months. And here you can see early metastasis to bones. And on imaging, it is similar to Wilms tumor. It is difficult to differentiate with a solid tumor with areas of necrosis and hemorrhage. Next is a rhabdoid tumor, which is a rare aggressive neoplasm seen in less than 2 years. And here it is associated with a synchronous primary or secondary intracranial neoplasms in 15%, usually posterior fossa midline tumors. Again, imaging is similar to Wilms tumor. Here you can see a mass lesion in the left kidney, which turned out to be a rhabdoid tumor. Rarely, renal cell carcinoma is seen. In children, it is differing from adult RCC in histopathological spectrum, And the most common type is the XP11.2 translocation, followed by papillary, clear cell, and medullary carcinoma, and association with von Hippel-Lindau syndrome can be seen in pediatric age group. And next malignant tumor is the primitive neuroectodermal tumor of kidney, which is a very rare aggressive disease with rapid progression, local recurrence, and early metastasis to nodes, lungs, pleura, bones, liver, and lymph nodes, and usually older age group, that is adolescent and young adults, with slight male preponderance. Again, the patient has a large mass with heterogeneous enhancing hemorrhage and necrosis with ill-defined margins. And very rarely renal synovial sarcoma, again in older age group with slight male preponderance. Coming to benign lesions, is a congenital mesoblastic nephroma. It is a histologically similar tumor in appearance to leiomyoma. It occurs within the first 6 months of life or intranatal, which is the diagnostic clue. And then it can be associated with gastrointestinal and genitourinary anomalies, and also associated with polyhydramnios. Next, there are two types, that is cellular and classic. Cellular usually presents late, that is more than 3 months, which is more aggressive and more cystic in nature. Whereas classic, it is predominantly solid, which is presenting early, that is less than 3 months, with less aggressive behavior. Another benign tumor is the multilocular cystic renal tumors. That age group include 3 months to 2 years, with a second peak at 5th or 6th decade, that is middle-aged women. And imaging shows a cystic lesion with thin septations. And here you should consider a very extremely rare differential diagnosis of a cystic Wilms tumor, where it can also present with a multicystic lesion with enhancing septations. So this is a multicystic tumor of kidney with enhancing thin septations. And rarely metanephric adenoma is a benign lesion, which is a rare tumor from differentiated epithelial and stromal component. The spectrum includes a purely epithelial component, that is a metanephric adenoma seen in adults. Next is a purely stromal component, that is metanephric stromal tumor seen in 2 years to 15 years of age group, and a mixed component, that is metanephric adenofibroma, that is 7 to 8 years of age group. And this is a coronal image showing a metanephric adenoma. There is a hypodense well circumscribed lesion in the right kidney, which turned out to a metanephric adenoma. And angiomyolipoma in pediatric age group, it is always associated, almost always associated with tuberous sclerosis. And it occurs early by 10 years and usually multiple, bilateral, and larger. And other lesions should be looked for, cysts, RCC, and polycystic kidneys. And this is an image showing bilateral angiomyolipomas, multiple lesions in both kidneys showing fat attenuation. This is angiomyolipoma. Thank you.
So, so as far as PGs are concerned, like the pediatric renal masses is a very important topic, and you are likely to get a case for your exams. And I think Dr. Amrita has presented her case as well as given a short description of all the possible pediatric renal tumors. And the others are rare, and Wilms tumor, as you know, is the commonest. And there are a few differentiating features which she has enumerated well, like clear cell sarcoma, which presents with skeletal metastasis, and rhabdoid tumor, which presents with brain lesions as well. And the age group is very important because some tumors occur within the 6 months of life, the solid tumors. I think she's enumerated everything very well, and I ask Danya to take over.
Amrita, you have presented very nicely, and we will go little more basic. And if your mother with a kid, came to the clinician with a suspected abdominal lump for the kid, and the clinician has taken an X-ray abdomen, but we will look for in the plain radiograph.
Plain radiograph, any soft tissue opacities can be looked for in the abdomen with any
Yeah.
predominantly, madam, for renal masses are you asking for?
Pardon?
Uh,
Suspected in case of abdominal, not pertaining to this case.
okay. So, you can look for the soft tissue opacities in the abdomen and any displacement of the bowel loops.
Yes.
So, if any calcifications,
Yes.
then level of the diaphragm, then any associated lesions or
Associated any bony abnormalities, or we can also look for other mass mimicking things like loaded colon, constipated child, or whether it is due to over distended urinary bladder. All those clues we will get from the radiograph. And if we are seeing a calcification left side of this thing, the stomach shadow will be displaced towards the higher side, and the bowel loops will be displaced. All those clues we will get from the radiograph. Okay, what are the features of this tumor, whether it's a retroperitoneal or intraperitoneal? What are the features in your case, in this case?
so here the mass is yeah, first of all, we can demonstrate a close sign, that is organ of origin can be demonstrated. You can clearly see the interface between the mass and the right kidney. So which presents that the mass is originating from right kidney and it is displacing the inferior vena cava medially.
Yeah, and the duodenal loops are displaced anteriorly. That indicates, anyway, it indicates it's a retroperitoneal mass. And what are the signs to identify the organ of origin in the retroperitoneal tumor? Whether it is a primary retroperitoneal mass or whether the tumor arising from any organ.
First is a close sign.
What are the signs?
First is a close sign or
yeah, that's one. Next.
Next is a organ embedded sign. So if the mass is not arising from adjacent organ, then the mass will be compressing the organ and distorting into a crescent shape. That's a organ embedded.
Then if it is compressing and it's a crescent shape, then it is?
It's not arising from the.
Yeah.
Then you have feeding artery sign. Feeding
phantom organ sign.
In case of masses arising from small organs like ovary, then that mass will not be seen separately. That organ will not be seen separately from the mass. That's a phantom sign.
Which sign will you see in usually seen in neuroblastoma like lesions?
Neuroblastoma.
Yeah.
Neuroblastoma, you can see organ embedded sign.
Really? In Wilms tumor, which all signs you can see, as in our case?
In our case, close sign is seen.
Then organ and embedded sign is also we can see. And when we see, usually neuroblastoma, large tumors, can we identify the adrenal?
Adrenal is rarely phantom sign is seen in the case of adrenal.
In neuroblastoma, you usually see in the phantom. Okay, and if you are doing IVU, what will be the sign? What are the radiological finding you get in Wilms tumor and neuroblastoma?
In the case of Wilms tumor, the pelvis, the calyceal system will be distorted. Involved poles. There will be distortion of the calyceal system, or if it is compressing, then dilatation of the calyceal system can be seen in case of
yeah, more of central tumors will get more of hydronephrosis and distortion, and in the polar lesions, and more of it is superior and posterior lesions causes more distortion of the calyces than the lower and anterior, because there is more space to exophatically expand the tumor. And if it is in the neuroblastoma, what will be the finding?
If it is in
What will be the position of the kidneys?
the kidney will be displaced anteriorly,
Basically, infralaterally.
infralaterally. Okay.
And what about the calyces? Have you heard of drooping lily? Drooping lily sign?
Yes, ma'am.
In neuroblastoma, we can get, and where will you get next? In neuroblastoma, because of the calyceal compression, renal compression, you can get the drooping lily sign. And in double moiety, duplex moiety, because of hydronephrotic moiety, you can also get the drooping lily sign. Okay. And congenital mesoblasthic nephroma, and what is the difference of the Wilms tumor age group difference if it is associated with the syndrome and or sporadic Wilms? If it is syndrome associated one, comes a little bit early, and it comes around in the age group around 9 months. So close differential in that setting, it will be congenital mesoblastic nephroma.
Okay.
And how will you differentiate congenital mesoblastic nephroma from Wilms in that situation? Age to both almost 6 to 9 around. I mean, congenital mesoblastic nephroma, it comes little early, 3 to 6 months. And the capsule, Wilms tumor, you told there is a pseudo capsule. That capsule will be deficient in the congenital mesoblastic nephroma, so the margins will be ill-defined. And the congenital, rather than a polar location, congenital mesoblastic nephroma usually comes within the sinus, central location, rather than the polar. Okay. Then is there any difference in the following of patients with the syndromic, syndromic and the sporadic Wilms? How will you do the follow-up scans? In syndromic one, you have to do every 3 months up to 7 years. But in case of sporadic Wilms, we have to do the 3 month scan up to 2 years, and then every 6 months for the next 2 years, and then every year till the baby is 7 years. Until after the 7 years, you can stop the follow. And after 7 years, Wilms tumor is very, very rare. Okay.
So I think there are no more questions in the chat box. So I invite Dr. Shruti for her presentation.
Good evening, all. Is the slides visible?
Yes.
Yeah, visible. Yeah.
Good evening. I'm Dr. Shruti Babu, the MD resident at Lakeshore Hospital. And today I'm presenting a case. Today, I'm presenting a case of an 18-year-old female presented with history of irregular period since 2 months of duration and abdominal pain since 3 weeks of duration. The patient underwent an ultrasound abdomen, which showed a lobulated heterogeneous solid lesion in the abdomen, and ovaries were not seen separately. And she underwent certain lab investigations, which showed an elevated LDH value of 1195 unit per liter. HCG were within normal limit, and a CA125 were minimally raised. The patient then underwent an MRI abdomen. These are the actual T1 and T2 weighted images showing hypointense multilobulated lesion in the pelvis, axial images through the pelvis in T2 weighted images showing a multilobulated solid mass, which is showing heterogeneous signal intensity in T2 weighted images. We can see intermediate signal intensity areas, high signal intensity areas, and few irregular fluid intensity areas within the solid mass lesion. This is a right ovary, which is seen in the supralateral aspect of the mass. We can clearly see the left ovary here, while free fluid is also seen in the pelvis. Uterus is also seen, which is inferiorly displaced. And this is the right gonadal veins, right ovarian pedicle, which is seen entering into the mass, suggesting the ovarian pedicle sign, suggesting that the lesion is arising from right ovary. We can also see a large right para-ovarian cyst. This is a coronal and sagittal images showing the multilobulated heterogeneous lesion, which is compressing and inferiorly displacing the uterus. The diffusion weighted images showing intense restriction in the solid areas. The post-contrast coronal images showing solid mass in the pelvis. The non-enhancing component is also seen within the mass. So to sum up, there was a large 12.8 into 8.4 into 12.2 centimeter multilobulated T2 heterogeneous signal intensity solid mass with intense diffusion restriction, which is seen arising from the right annexa as evidenced by the vascular pedicle sign. The solid portions show heterogeneous contrast enhancement, and right ovary with follicle is seen in right superlateral margin of the mass, which was inseparable from it, and a unilocular 10 centimeter right para-ovarian cyst. Uterus was displaced anteriorly and inferiorly by the mass. So, solid right annexal mass in an adolescent female, and the organ of origin is from the right ovary as evidenced by the vascular pedicle sign. So coming to the differential diagnosis, in this 18-year-old female with abdominal pain and menstrual irregularities, the primary LDH values, the primary concern is that of germ cell tumor. Other differentials to be considered include subserosal uterine fibroid, desmoplastic round cell tumors, ganglioneuroma, and GIST. The patient underwent PET CT scan, which showed these are the axial CT images at this level of pelvis, showing the soft tissue solid mass lesion. The coronal image CT images of the abdomen and pelvis other than the mass lesion. The FTG PET images showing high PET uptake in the solid mass in the pelvis. of SUV max 11.5. Other petavid lesions were found elsewhere in the abdominal pelvis. The final diagnosis was an ovarian malignant neoplasm, likely germ cell tumor. The patient underwent right salpingo-oophorectomy followed by resection of enlarged pelvic and para-aortic lymph nodes and infracoronary omentectomy, and the histopathology came out as dysgerminoma, and the tumor invaded the capsule at places. There was no lymphovascular invasion, or pelvic and para-aortic lymph nodes were free of disease. So a few words about the germ cell tumor. Germ cell tumors are usually benign. They can be malignant also. And mature teratoma is the most common type of benign ovarian germ cell tumor, usually growing in teenage girls and young women. Dysgerminoma is the most common malignant ovarian germ cell tumor. Most ovarian germ cell tumors are treatable. For malignant tumors, the prognosis depends on the tumor size and distant metastasis. This diagram showing dysgerminoma comprising the largest proportion of malignant germ cell tumor, followed by teratoma, yolk sac tumor. Other germ cell tumors includes ovarian teratoma. Ovarian teratomas can be mature ovarian teratoma and immature ovarian teratoma. Specialized teratomas of the ovary include stuma ovary tumor and ovarian carcinoid tumors. Then ovarian dysgerminoma, yolk sac tumor or endodermal sinus tumor, ovarian embryonal carcinoma, choriocarcinoma, malignant mixed germ cell tumor of the ovary. The complications of ovarian tumors include rupture, torsion, malignant transformation, usually into squamous cell carcinoma, then superimposed infection, hyperthyroidism in case of stuma ovary, then carcinoid syndrome. Next, about how to differentiate between mature and immature teratoma. Mature teratoma are more common in occurrence compared to immature teratoma, and mature teratoma are more benign, and the age of presentation is second and third decade in case of mature teratoma, whereas immature teratoma occur in more younger age group. Mature teratoma are smaller, usually less than 10 centimeter, and they are more cystic with more fatty component. Immature teratoma are large encapsulated masses which have a prominent solid component. Elevated serum AFP levels are seen in immature teratoma, whereas it is not seen in mature teratoma. We can get CA99 elevation in mature teratoma. In immature teratoma, CT and MRI show a prominent solid component which can contain calcification and small bouquet of fat. Whereas in mature teratoma, fatty component and calcifications are more with diffusely or partially echogenic mass with posterior acoustic shadowing owing to the sebaceous material and hair within the cyst cavity in ultrasound. CT images can demonstrate fat fluid level, calcification, Rokitansky protuberance, and tuft of hair. These are the CT images showing mature teratoma, which is containing predominant fat and areas of calcification. It's an immature teratoma, which is more complex. Then few words about dysgerminoma. Dysgerminomas are ovarian counterpart of seminoma, occur in teenage girls or young women. 17% can occur bilaterally. Some of the dysgerminomas produce beta HCG, which is seen in some cases. In that case, it will be useful in postoperative follow-up of the patient. Dysgerminomas tend to grow and spread slowly, and they are the most common type of malignant tumor. Thank you.
So thank you, Dr. Shruti, for the presentation. And I now request Dr. Dhanya to take over.
Shruti, which is a primary imaging modality for suspecting an ovarian tumor?
Yes, ma'am.
What is the ultrasonological features to differentiate between benign and malignant ovarian tumors?
In benign tumors, if we are seeing cystic lesion without septae, thick wall septae, mural nodule, it will be more towards benign. And if we are seeing thickened irregular septations, solid components, vascularity within the solid component, and large.
And any size criteria for the lesion, septae, anything?
Sorry, ma'am.
Any size criteria for the lesion
If it is
size, septal thickness?
less than 10 centimeter,
Lesion more than 4 centimeter and septal thickness more than 3 mm. It's suspicious of malignancy. What are the Doppler parameters will you look for?
color signal intensity.
Yeah. What will be the flow pattern? Usually in the malignancy, there will be low resistant pattern. And the RI will be less than 0.4 and PA will be less than 1.4. And have you heard of ORADs in which?
Yes.
In which category in our case includes?
ORADs 5.
Okay. What are the features in ORADs 5?
Solid, enhancing solid component, then associated any features of peritoneal spread like ascites, nodal spread.
If it is a unilocular cyst, if there are more than 4 papillary projections, or multilocular cyst with any solid component with a color score of any 0 to 3, or any solid irregular lesions of any size. All this comes under ORADs 5. Okay. And what is the in young age group, we told it's a germ cell tumor is most common. And what is the difference between epithelial tumors and germ cell tumors? Age group. Age group, you told it's in the germ cell tumors comes in the younger age group.
Younger age.
And bilaterality, common in which type of lesions, whether it is epithelial or germ cell tumor?
Epithelial tumors.
Bilaterality common in?
Epithelial tumors.
Epithelial tumors. Okay, then other markers like AFP, beta HCG, everything will give clues in germ cell tumors. And then endocrine manifestations in the that is also more common with germ cell tumors, and it's never occurs in the epithelial tumors. And have you heard of growing teratoma syndrome? It occurs with the germ cell tumors. So basically, it's a complication after the treatment of the metastatic non-seminimatous germ cell tumors. That the tumor mass per se grows, continues to grow. The growing tissue will be the mature elements, and the lesion will be serologically negative. And then what? Have you heard of collision tumor? This commonly occurs within ovarian lesions. Okay, the tumor with the two adjacent, but the two histologically distinct tumor close together, but without histological intermixing of the histological features. So most common collision tumor is teratoma and cystadenocarcinoma and cystadenocarcinoma. That is the most common one. And then in this age group, in adolescent age group, we told what are the DDs you told? In this ovarian tumors,
And subserosal uterine fibroids, round cell tumor, GIST.
yeah, in this ovarian tumors. I'm asking about regarding the subserosal fibroid, which sign will you help to differentiate whether it is uterine origin or ovarian origin?
Ovarian pedicle sign, ma'am. The gonadal veins.
Yeah. Have you heard about bridging vessel sign? Ovarian pedicle, that is also fine. We can see the draining vessels, whether it is supplied by ovarian artery and ovarian vein, that is fine. And another sign is bridging vessel sign. That is that is the appearance of the vessel coursing from the uterus to that adjacent pelvic mass. And if it is that mass is supplied by the uterine vessels, and it is the likely subserosal fibroid. Okay, what are the DDs? Ovarian tumors in the adolescent age group.
Yolk sac tumor, teratomas.
Teratomas, but it's not fat containing, like in our case, solid ovarian tumor without any fat. What are the DDs in the
Yolk sac tumor.
adolescent age group? Dysgerminoma, fibrothecoma, sexcostomal tumors in this younger age, granulosa cell tumors, and others, Brenner tumors, etc. What is the MRI feature of fibrothecoma? What will be
T1, T2 hypointense.
Yeah, T2 it will be low signal. And what are the additional finding in granulosa cell tumor? Granulosa cell, you will have the estrogenic effect and you will get enlarged ovaries, endometrial polyps, endometrial thickening. All that additional features will give the clue towards the granulosa cell tumor. And there are two types of granulosa cell, that is adult and juvenile. The adult one is most common than the juvenile one. Okay.
So there has been a question in the chat box regarding the differentiating points between immature and mature teratoma. So for the benefit of the pages, can you please explain it once more? Shruti?
Yes. Mature teratoma is the most common type. Immature is comprising only 1% of total ovarian teratomas, ovarian tumors. And mature teratoma are benign, and immature has more malignant potential. Immature teratoma has more younger age of presentation compared to mature. Teratomas are more usually smaller, and more cystic and fatty component will be more in mature teratoma. Elevated serum AFP level will be seen in immature teratoma, and the predominant solid component on imaging will be seen in immature teratomas with few fatty and calcific foci. The typical USG features of mature teratoma includes diffusely or partially echogenic mass with posterior acoustic shadowing or into the sebaceous material and hair within the cyst cavity. Mural hyperechoic Rokitansky nodule. CT can demonstrate fat and fat fluid level, calcification, and Rokitansky protuberance and tuft of hair in mature teratoma.
Can you show the picture once again? So as she has said, mature teratomas contains more of fat, but immature teratomas would have more of soft tissue components, less of fat, few calcification. Mature teratomas would have large chunky calcification. Dr. Venu, anything more to add? Dr. Venu, are you here?
Yeah. That's all. No, the thing is, mature teratoma, the lesion as such will be well circumscribed, whereas in immature it will be poorly defined, because actually there's a malignant transformation is there. So we cannot expect well-defined mass in the immature teratoma. That's all. Calcification and all. Anyway, immature teratoma most often we cannot diagnose imaging wise. So we have to put DD as dysgeminoma as well. So only by biopsy we can confirm. A mature teratoma is a spotter.
Yeah. And more often this mature teratoma often missed in ultrasound also because of the fat.
Yeah,
We
yeah.
Even echogenic shadows, no? So we think it's a bubble. So often missed in ultrasound also. But the immature teratoma will never be missed in ultrasound.
I think we have a few spotters also. Dhanya,
Yeah.
can you
Yeah.
please start your slides?
Shruti,
Yes, ma'am.
can you stop sharing your screen? Shruti, you can stay back. There are only 10 spotters. Shruti, case 1, the 55-year-old lady with abdominal mass for evaluation.
Can you slide share it? Dhanya? Dr.
Yeah,
Dhanya?
fine. Is it visible?
Yes.
Okay, Shruti, carry on. What are the findings?
The axial CT images showing in the plain image, we can see well-defined cystic lesion in the lower abdomen with chunky calcifications. In the post-contrast image, we can see enhancing septae.
What it could be?
Uh,
What is your diagnosis?
It can be any mucinous or any epithelial neoplasm of the ovary, usually, most likely malignant due to the enhancing
Yeah.
septins multiple.
That's fine. And what is the difference in calcification between the mucinous and the serous cystadenocarcinoma?
More coarse calcifications are seen in mucinous type compared to serous.
The thing is, the calcification is more common. I mean, linear calcification is more common in mucinous one. In serous, because of papillary projections, there is a samama body formation that causes concentrically laminated calcific concretions. This is chunky papillary projections causing chunky calcifications. That more favors towards the
Serous type.
serous cystadenocarcinoma.
Okay.
And have you heard of HIPEC? HIPEC is a heated intraperitoneal chemoperfusion. That is an adjuvant chemotherapy performed in conjunction with the cytoreduction. And usually it's done in the peritoneal disseminated lesions like pseudomyxoma, mucinous adenocarcinoma of appendix, peritoneal mesothelioma, and peritoneal carcinomatosis. And it's usually in MDCT, pre-HIPEC will take the MDCT and we'll calculate the peritoneal carcinomatosis index, and that's grade from 0 to 39. And if it is more than 20, the prognosis is very poor and they won't do this HIPEC surgery. And if it is less than 20, they'll go for cytoreduction surgery and HIPEC. Then case 2, it's a 17-year-old female with abdominal pain. What are the findings?
We can, in the T2 weighted axial images at the level of pelvis, we can see an enlarged, centrally located ovary, and normal left ovary is seen adjacent to it. So with mild free fluid is also seen. The post-contrast images, we can see normally enhancing left adnexa, and there is no enhancement in the right ovary. So it is a torsion of right ovary.
Yes, torsion. Definitely torsion. Why ovaries enlarged? What is the cause of torsion?
The ovarian pedicle is twisted, leading to congestion.
Yeah, that is the one cause. There is ovarian complete torsion of the ovary to the extent of venous and lymphatic drainage compromise, but it's insufficient to cause the complete necrosis of the ovary. Ovarian edema syndrome, and it's a tumor mimicker. And other theory regarding this ovarian edema, it's a lymphatic dysfunction that is usually seen in patients with taking ovarian induction therapy for infertility. Next, it's an mini spotter.
This is an axial CT image at the level of pelvis showing well-defined cystic lesion with some hyperdense contents within.
Yes.
Anterior to the uterus.
Shruti?
Yes, ma'am. Bilateral ovaries are not seen, not visualized. Can it be any cystic neoplasm from pelvic adnexa?
Okay, it's an mini spotter. This is a retained sponge with a foreign body reaction, gosipiboma. There are two types of reactions. One is the aseptic fibrotic type of reaction with macrophage and monocyte invagination towards it, and there is aseptic adhesion also occurs, and there is thick fibrinous capsule forms. That is completely aseptic. The classic CT picture is thick walled cystic lesion with hyperdense linear contents. That is a sponge itself. And the other variety we used to see with mottled gas bubble appearance with a thick walled surrounding. That occurs due to the exudative inflammatory reaction with secondary bacterial contamination causing mottled gas bubble appearance. These are the two pictures, and the left one shows the exudative type of foreign body reaction causing the thick walled fibrinous covering and with the central motile gas bubble appearance. And the right one shows the aseptic fibrinous foreign body granuloma formation. In the case for it's a 31-year-old female on follow-up with pelvic surgery for dysgerminoma. The follow-up CT is taken.
Axial plain CT images showing a soft tissue lesion anterior to the left rectus abdominis muscle.
Yeah.
So considering the history of the patient, it can be an ovarian transposition.
Yes, exactly. Why is it done?
To conserve the fertility of the patient in order to avoid radiation exposure.
Yes. What are the common sites? Where will you do? What is the indication for doing? What are the conditions? Usual scenario. It's usually in the younger
young females.
Premenopausal women with cervical malignancy, rectal lymphoma, in order to prevent radiation injury to the ovary. The ovary is transposed to the higher level away from the radiation field. And it can be either in the lateral paracolic gutter or anterior to psoas muscle and above the pelvic brick. And what are the complications associated with this procedure?
Necrosis.
Yeah, it can undergo torsion and necrosis, and the recurrent tumor is also another complication. Next one, 63-year-old female with bleeding per rectum.
There is asymmetric circumferential enhancing wall thickness at the rectosigmoid.
Yeah.
Okay, there are heterogeneously enhancing lesion in the bilateral ovary. So
Yeah.
can be a primary bowel neoplasm with metastatic tumor or Krukenberg's tumor in the ovary.
Yes, yes, exactly.
Solid with enhancing component.
Okay, what are the causes of Krukenberg tumor?
So
What are the causes of bilateral ovarian metastasis?
CA stomach, CA breast.
GA is the most common cause, and
Yes.
other sites are breast, lung,
Breast.
and cholangiocarcinoma, GB.
Okay.
Next one is case 6, 30-year-old female with epigastric mass for evaluation. CT sections show.
Okay. There are multiple fatty.
Amrita is there. Amrita can take over.
Yes, ma'am. The axial CT sections showing there is a solid cystic lesion towards the left side of the abdomen, showing cystic areas and solid components, and a few coarse calcifications are seen.
Are they fully cystic or?
Salt areas are also seen with thick septations are seen.
What is
Coarse
attenuation? Attenuation looks like in the area of liver.
There is low fat attenuating areas.
Yeah, that's true.
Yes. So there are areas of fat attenuation calcifications suggestive of teratoma.
Yeah, it could be some teratoma with rupture or immature teratoma with metastasis.
Okay.
What are the causes of fat-containing liver lesions? Name a few fat-containing liver lesions.
Myolipomas.
Yeah, angiomyolipoma.
Then focal fatty changes can be seen. Focal fatty infiltration.
Yes.
And FNH, focal nodular.
FNH or adenoma, which is more common, more common in what?
FNH.
Adenoma.
Adenoma. Okay.
Then
lipoma can occur in
yeah. Malignancies associated with fat.
Liposarcoma.
Yeah. Liposarcoma, primary and secondary liposarcoma, and 15% of HCC can also cause fat. Okay, next 24-year-old female with pelvic mass. Yes, describe the lesion. Where is it?
There is a coronal T1 image showing T1 isointense mass is seen in the pelvis, lobulated T1 isointense mass,
Yeah.
and T2 weighted sagittal section shows large T2 heterogeneous lesion inferior to the uterus, T2 hyperintense areas.
Yes.
Is involving the vagina also.
In the region of vagina.
Yeah. And still hyperintense areas
displacing the uterus superiorly.
Superiorly, yes.
T2 post-contrast study, and there is T2 hypointensity areas within. In a young female, what is the diagnosis? aggressive angiomyxoma. That's usually occurs in the mesenchymal tumor. It's basically benign but locally aggressive type of tumor, occurs in young females. And the classic sign is swirl sign that you can see in T2-weighted coronal and post-contrast study. The T2 hypointense fibrovascular core you can see within the hyperintense myxoid tissue. That is the classic sign. It's usually seen in 85%, around 85% of the angiomyxomas. What are the causes of the any cystic lesions in the region of vagina?
Bartholin cysts can be seen.
Yeah, Bartholin cyst. Gardner, Bartholin
Gardner cyst.
lymphangioma, etc. Okay. Next, 24-year-old female with abdominal pain.
The axial T1 weighted image showing a lobulated lesion
Yes.
in the pelvis.
Yeah.
With T1 hyperintense areas within.
Yes.
And a T2 weighted axial image shows T2 hypointensity. Sagittal T2 section shows T2 shading is seen. T2 shade.
Yes.
And there is no enhancement post contrast. Most likely a hemorrhagic cyst. Endometrial cyst or hemorrhagic.
That's correct. What is there in the uterus? Adenomyosis, widening of the junction zone, heterogeneous thick and posterior myometria, and T1 hyperintense areas also seen. It's a typical of adenomyosis and endometriotic cyst. What are the signs in MR?
T2 shading.
Yeah.
T1 hyperintense due to blood, presence of blood.
Yes. And because of the adhesions, you can see the kissing ovary sign. And if it is solid deposits in the rectouterine region, you can see mushroom cap sign. This is a mushroom cap sign. It's the hypointence, the inferior portion, inferior base is due to the fibrotic endometriotic deposit and the hypertrophic muscular propria. And the hyperintense cap is due to the high signal mucosa and submucosa that is displaced towards the bowel that forms the cap of the mushroom. That is a mushroom cap sign. This is a typical barium, double contrast barium enema picture. There is classic teaching circumferential narrowing with the luminal narrowing with the mass effect, speculation and pleated appearance of the anterior margin. That is the typical description of the endometriotic deposit in the rectosigmoid region.
Okay.
Next, the 27-year-old female with abdominal pain.
Axial T2 weighted image shows T2 hyperintense multiloculated cystic lesion in the pelvis.
Yeah.
Fluid levels can be seen. Both ovaries are seen separately.
Is it separate from the lesion or?
It is abutting the ovaries.
Ovaries are encased within the lesion, right?
Okay.
Lesion is extending superior up to the superior part of the ovary, and both ovaries are seen partly encased within the lesion. And is there any enhancement after the post-contrast study? There is no solid,
enhancement.
no solid component, only wall shows enhancement. There is a lack of discrete limiting wall.
Yes.
That is a diagnosis. Patient is giving a history of surgery 2 years back.
Then inclusion system.
Yeah, that's right. Peritoneal inclusions. That's a typical accumulation of the ovarian fluid contained by the peritoneal adhesions because of the previous surgery. Then there is invagination of the surrounding structures into the cyst. That's why ovaries are seen within the cystic lesion. And there is lack of discrete limiting wall, no enhancing neural nodularity, and minimal internal debris can be there. What is do you know the ORADs for the this kind of lesion, peritoneal inclusion cyst? It comes under ORADs 2. That's typical features like hydrosalpine, endometriotic cyst, all those hemorrhagic cyst, all comes under ORADs 2. Next, 14-year-old female with a dyspnea and abdominal distension.
So first is axial CT section showing bilateral moderate pleural effusion.
Yeah.
So next image through the sections through the abdomen showing large solid locally hypodense lesion in the right side of abdomen.
Yeah. Any ascites?
Yes, there is ascites.
Yeah.
Ascites. So the can Meeks syndrome.
Yeah, that's true. That's true. What is the diagnosis complete? What is the solid tumor is?
Ovarian fibroma.
Yeah. What is the MRI picture for that? Ovarian fibroma. What will be this?
T2
hypointensity. That is a ovarian fibroma. And what are the? Have you heard of pseudo-Meek?
Pseudo-Meek syndrome.
Pseudo-Meek syndrome.
Case of
that is a pleural effusion. That is benign reversible pleural effusion in the presence of a primary tumor in the abdomen, other than the ovary, like broad ligament leiomyoma, like that. That is pseudo-Meek. Last one. 37-year-old lady on infertility treatment presented with abdominal distension and dyspnea. So on many cases, just diagnosis.
So first image showing bilateral myopleural effusion. And, section through the pelvis shows multiple cystic lesions in both ovaries are enlarged with cystic lesions in both ovaries with no enhancing solid components and mild ascites. So it can in the given history, it may be an ovarian hyperstimulation syndrome.
Yeah, fine. Finish. Ovarian hyperstimulation.
Yeah, so that is all for today. I think there is one question in the chat box, like how do you differentiate between peritoneal inclusion cyst and lymphangioma? So I think lymphangioma is a multiloculated lesion, benign lesion, which insinuates between the organs, and then peritoneal inclusion cyst actually is seen around the ovaries. Ovaries are entrapped by the peritoneal inclusion cyst, and then it keeps on enlarging with time because of ovulation. I think those are the differentiating
Also,
features.
there would be an enhancement in lymphangioma.
Yes, yes,
Because
yes.
thin wall, and you won't get enhancement, appreciable enhancement in lymphangioma.
So, and somebody has asked to explain case number 5 again. Danya, can you please show case number 5?
It's an MRI section showing the diffuse circumferential thickening of the rectus sigmoid and the bilateral adnexal ovarian enlarged ovaries with enhancing components. It could be either primary rectus sigmoid with Krukenberg tumor, or other DD could be bilateral ovarian tumor with the serosal deposits causing rectus. It could be either way. Either colonoscopy will give the final diagnosis. It can rule out any mucosal involvement of the lesions. If you're ruling out mucosal involvement of the lesions, it could be the primary ovarian malignancy. And if mucosal lesions are, if it is the, you can take it as a primary rectus sigmoid with Krukenberg's tumor.
So if there are no more questions, I think, can we wind up the session, ma'am?
Yeah. It was a wonderful session and covered most of the ovarian lesions through the spotters and cases. It was really, really wonderful to see all the different varieties of ovarian lesions, including metastasis and primary. Thank you so much for presenting such beautiful cases. Thank you, Lakeshore team.
Venu sir, shall we wind up?
Yeah. Of course.
So I thank everyone from the organizing team who has made this possible. And I thank Dr. Danya for her contribution and for her excellent conduct of session. And I thank the PGs who volunteered for the session, and both of you have done a wonderful job. And they've explained everything, making our job easier.
Yeah. Both the residents did wonderful. They had really needs a big applause.
And I also thank Dr. Venu and Dr. Gomati for the contribution. And I thank Dr. Gina for the comments. And I thank the MedPiper team for their excellent technical support. I take this opportunity to thank each and every one of you who have attended this session, and hope the sessions were useful for the PGs. And so we are closing the session for today, and I request all of you to attend the next session.